Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ardelyx.
Good afternoon. How are you feeling after today's treatment?
Pretty good, Doc. A little tired, but that's not new these days.
Yeah, it's quite common. So I wanted to go over your recent lab results with you. Your phosphate level is still high at 6.2. Last month it was 5.9, so we're not seeing the improvement we'd like to see with the phosphate binder treatment.
I figured you'd say that. Honestly, I don't think those binder pills are working. My levels haven't changed much since I started taking them.
I understand your frustration. Are you taking the phosphate binders with all your meals?
Well, I tried to, but it's not always easy to remember.
Can you tell me more about what makes it difficult?
My wife and I go out to eat a lot, and I forget to bring the binders with me most of the time. Plus, they're just large pills, and I have to take so many of them each day. It's hard to eat when I take them. I don't know. I just don't really like taking them in general.
I see. Let me explain why it's so important that we get your phosphate levels under control. When your kidneys aren't working properly, they can't remove phosphate from your blood effectively. Even adequate hemodialysis can't remove enough phosphate to keep your levels controlled. This leads to hyperphosphatemia, high phosphate levels, which can cause problems with your bones and your heart over time.
Oh, I didn't realize it was that serious.
So far, your other labs look good, but controlling phosphate is really important because when it's high, it can cause problems with other labs like calcium and parathyroid hormone.
Well, why isn't the binder helping?
The binders work by binding to the phosphate in your food, so it can't be absorbed into your bloodstream. But they only work well if you take them at the right time with meals.
I see. I try to take them, but like I said, they make it harder for me to eat. I start feeling full right away.
I see. What about snacks? Do you eat between meals?
Yeah, sometimes. Usually in the evening, I have something while watching TV.
Well, if you're having a large snack, especially one that's high in phosphate like processed foods, you should take a binder with that too. The key is matching the binder to when you're eating phosphate.
I thought it was just supposed to be 2 tablets with every meal.
Well, really, you should be taking 2 sevelamer tablets with each meal. And if you have a substantial snack, particularly one that's high in phosphate, you should take 1 tablet with that as well. I know the binders can be challenging to take, but they are often effective when they're taken correctly.
I see.
Can we make some adjustments to help you succeed?
Yeah, I guess. What should I do?
Well, we have a few options. We could increase your dose to 3 tablets with each meal and 1 tablet with any large snacks, or we could switch to a different type of phosphate binder and see if it's any easier for you to tolerate.
Think I'd rather try taking them the way you're suggesting first, being more consistent with the timing because I don't really want to switch to something else right now if I can avoid it.
That's a good choice. Consistency is really key here. Let me give you some practical tips. Consider keeping a small container of binders in your car, or ask your wife to keep some in her purse when you go out to eat. And remember, the timing matters. Take them right before or during your meal.
That's actually a good idea about asking my wife to carry some with us.
I'm also going to put a note for our dietitian to review a low phosphate diet with you at your next visit with her. She can help you identify which foods are highest in phosphate and discuss better food choices, especially when you're eating out.
Okay, sounds helpful. So we'll try this for a while and see how my levels look.
Exactly.
Hello, I'm Dr. Stuart Sprague, clinical professor of medicine at the University of Chicago Pritzker School of Medicine in Chicago, Illinois. I'm here to talk to you about phosphate control And we just saw a scene where a patient had suboptimal phosphate control with poor adherence to binder therapy. I think what we need to understand here is how phosphate binders actually work. Phosphate binders work within the lumen of the gastrointestinal tract by binding the free phosphate that's there. This phosphate is released from foods and is also associated with supplements in the food. And the binder acts by binding with the phosphate so it's not absorbed and then is then excreted with your stool. The phosphate is actually passively absorbed in between the intestinal cells to an area called a tight junction. And the amount of phosphate absorption has to do with the concentration of the free phosphate within the gastrointestinal tract. So, the more phosphate in the diet, the more binders someone has to take in order to maintain control of the serum phosphate. This actually turns into problems for our patients because the binder has to be taken with the meal. It's got a short duration of action and the limited ability of each pill to actually bind the amount of phosphate. Also, the patients have to take a relatively large tablet, as with most of these phosphate binders are large. They have to take it multiple times a day, basically every time they eat. And the patient takes an average of about 10.8 pills per day. And this results in the phosphate binders accounting for about 50% of the daily pill burden for patients on dialysis, which means these patients are taking well over 20 pills a day. So, what we need to do is educate our patients on how important it is to take the phosphate binders, that they have to take them with their meals and when they have large snacks. There is some data coming out with newer binders, which are a little bit smaller and are able to bind phosphate a little bit more effectively. Shown here are the various binders we have, such as iron binders, calcium binders, lanthanum binders, but there's a new binder called oxylanthanum carbonate, which actually has a high phosphate binding capacity with a low medication volume. So, what we need to do is encourage our patients to minimize their sources of phosphate, to take their binders with their food, and have monthly visits with their dietitian. Now, I would like to move into how our patient is doing after making adjustments to his phosphate binder regimen.
So I have your latest lab results here, and it looks like your phosphate level is rising again. Last month it had improved, but now it's back up again.
It's frustrating. I've been taking the binders better now, like we talked about. I even take them with large snacks, but my level's still high.
I can see you're making an effort. How are you tolerating the Sibelamer? Any constipation or diarrhea?
I've been a little constipated, but I take a laxative. That helps. I'm just frustrated that my level's still high and I'm taking a lot of pills now. What is it, about 10 a day?
Yeah, I understand your frustration. There are a few options we can try. We could switch to a different phosphate binder, or we could consider a medication that works differently than the phosphate binder.
What do you mean?
Well, there's another medication that helps lower phosphate by blocking absorption of phosphate across the GI tract. It can be taken with your binder.
Some more pills.
Well, not necessarily. Can you tell me about your meals? What does a typical day look like for you?
Well, I usually have something light for breakfast, maybe a sandwich for lunch. My wife and I sit down and have a nice meal together for dinner, then usually a snack for bed.
So, would you say dinner is usually your largest meal?
Yeah, usually.
Well, that's helpful to know. What we can do is decrease your Sibelamer to 1 tablet with breakfast and lunch and 2 tablets with dinner, your largest meal. Then we'll add 1 tenapanor tablet twice daily, one in the morning and one in the evening.
So it's actually less pills in the end. Are there any side effects with the new medicine?
Well, it can affect your stools. And you mentioned some constipation. How often do you have bowel movements currently?
Not every day, but probably about 4 times a week. And that's with the laxative.
Okay. With the tenapanor, you'll likely have more frequent bowel movements. So you should stop taking the laxative. Your stools may also become looser because of how tenapanor works. This is normal and common, especially when you first start the medication.
What do you mean, how the medicine works?
In addition to reducing phosphate absorption, tenapanor also reduces dietary sodium absorption and increases the sodium and water content of your stools. This softens the stools and increases bowel movement frequency.
Okay, so I stop the laxative and expect to go more often.
Exactly. We'll keep an eye on it and adjust things based on how you are tolerating the regimen.
All right, I'm willing to try something different.
Great. The dietitian will also continue working with you on food choices to support these medication changes.
Well, our patient, in spite of having encouraged to take his phosphate binders and taking them as appropriate, was unable to maintain serum phosphate control. So we decided to treat him with a drug with a different mechanism of action, tenapanor. And as you can see here, phosphate, it passes through the lumen and goes through the intracellular areas. Tenapanor works by attaching to the gastrointestinal cells, and it causes the tight junctions to close. So therefore, it inhibits the ability of phosphate to passively go through the intracellular junction, and it therefore blocks the phosphate absorption without having to use a binder, and the phosphate stays within the lumen and then is excreted with the stool. It does cause a slight increase in the proton concentration within the cell, so a little bit of acidity, and it also causes a little bit of sodium retention within the lumen that causes some fluid retention and loosens the stools. If we look at the major study, which was called the Optimize study on the use of tenapanor, and this was a two-part randomized study in which patients were either switched from their phosphate binder to tenapanor, had binders reduced by about 50%, and then started on tenapanor, or they were binder naive and started on tenapanor. The patients had to be 18 to 80 years old, and they were on either hemodialysis and peritoneal dialysis, and they had to be inadequately controlled serum phosphate while they're on the phosphate binders. And as you can see, in a straight switch to tenapanor, we had about 34% of the patients getting their phosphorus less than 5.5, with a 0.91 reduction in the serum phosphate and a reduction of the pill burden from 9 to 4 pills. When the patients had their binders reduced by 50% and started on tenapanor, we saw 38.2% reduction in the serum phosphate to less than 5.5, with a mean reduction of 0.99 milligrams per deciliter, and the mean pill burden reduced from 9 to 6. And in the binder naive patients who were started on tenapanor, we saw a 63% patients achieving a phosphorus of less than 5.5 and a 0.875% reduction. The most common side effect was loose stools or diarrhea that occurred in about 40% of the patients, but again, it was fairly well tolerated. So again, what we want to do is address what we could do to help improve the phosphate with this new drug tenapanor. We do explain to the patient that it will cause looser, more frequent stools, not real bad diarrhea, but we have to warn them. And importantly, we have to make sure the patients know that they should stop any stool softeners they may be taking.
I have some good news. Your latest labs are looking much better overall. Your phosphate level has been decreasing since you started the new regimen. It's at 5 today, which is where we want to see it.
Wow, that's a relief.
Yes. And your other labs look good too. Your PTH is 410 and your calcium is 9.2, both within the normal ranges. How are you tolerating the new regimen? Have your bowel movements changed?
I'm much better now, but I was going about 2 times a day when I first started the new drug, but that's leveled off. Now I go most days, but just once.
Are your stools loose?
They were initially, but I would say they became more normal again after no, maybe about 3 weeks on the medicine.
Okay, that's about what we'd expect to see. It seems like your body has adjusted to the medication. Are you able to take both medications like we discussed?
Yes, I'm taking both. How you said, it helps to not take as many pills with each meal. Speaking of that, I was wondering if we can decrease the number of pills even more.
That's a good question. Since things have improved, let's recheck your labs in another month to make sure your levels are still stable. Then we can talk about adjusting things further.
Sounds reasonable. I have a few food questions for the dietitian too. I think I see her after you.
Yes, you will. I'm glad she's helping you. Keep up the great work with your medications and diet.
Thanks, Doc.
Okay, well, now let's look at how the patient responded since being on the tenapanor, and he had improvement of his serum phosphorus. As you can see, after 3 months of even dual binder therapy with tenapanor, his labs are, as noted, parathyroid hormone rather stable at 410, calcium at 9.2, the albumin at 3.8, his dialysis KT over B, which means appropriate at 1.5. His serum phosphate over the last 3 months was 5, 4.9, and 2 months ago it was 5.6. So as you can see, after 3 months of therapy, this patient is under better control. So what we got to do is we need to talk to them about it. It's very important that you address the patient's concerns. I think it's very important to explain to them as you started that you do take this pill once, twice a day. It does not have to be taken with the meals. It will cause loosening and more frequent stools. Overt diarrhea is really not a problem, but if you have it, let's talk about it and you can see how we could address it. Again, as I mentioned, you need to make sure they stop any type of stool softener that they're taking. And usually, when you start them on it, you don't want them to take their first pill just before they come to dialysis because you don't want them to have loose stools or have to go on dialysis. So they should take it after the dialysis treatment. I think it's very important that the whole team works here. And again, the physician who oversees this needs to directly educate the patient on how the drug works and what they should expect. The nurse is important to see how the patient is doing on a regular basis to make sure that they're doing okay. And it's important for the dietitian to continue to work with the patient in their diet in terms of how many phosphate binders they're taking, whether or not that needs to be adjusted up or down while they're taking tenapanor. In closing, I think we have found that tenapanor appears to be effective in order to get phosphate under control in patients who are unable to be controlled with phosphate binders. It greatly reduces the pill burden for these patients and becomes more convenient to take as they only have to take one relatively small pill twice a day and not with their meals. And they may end up more compliant with their other medications since they'll have a much lower pill burden altogether. I want to thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.